Good. Mohit, you on?
Morning, good evening, and good afternoon. I am Dr. Mohit Bhandari. I am the co-director of this course along with Professor Fobi, and we are at the 10th episode, pardon me, of the virtual Bariatric University. And today is a very interesting topic of SADI-S, a primary bariatric metabolic procedure, which is being performed in different parts of the world. We have a stellar group of faculty today. The leaders and somebody who have taught generations of surgeons in bariatric and metabolic surgery. First of all, I would like to introduce you to the faculty for today's course. We have Professor Antonio Torres from Spain. Antonio is was the IFSO president 2011 and 12 and the vice chairman of IFSO board of trustees. He is a professor of surgery, University of Madrid, and chief of the general and digestive surgery services at Clínico San Carlos Hospital. Dr. Torres is one of the leading authors of more than 200 peer-reviewed articles in the field of bariatric and metabolic surgery. He was a great host at the last IFSO, where all of us met physically in Madrid, and I had the honor of operating at his fantastic hospital in Madrid. So welcome, Professor Antonio. You have always been very kind to all your friends and colleagues and always promoted the field of bariatric surgery. A warm welcome to you. Next, we have Professor Daniel Cottam from USA. Dr. Cottam began his practice in Las Vegas and very specialized in bariatric surgery and abdominal wall reconstruction, complex revision bariatric procedures. He's the first surgeon in the United States to perform the single anastomosis loop duodenal switch along with Mish Roslin. And currently, Dr. Cottam works at the Bariatric and Metabolic Institute. In November 2019, Dr. Cottam was recognized for his innovative work by none other than the ASMBS Surgical Innovation Award. And one of the special highlights for Dr. Cottam was that less number of people know, but he was the first surgeon who performed surgery here in India. And at the same center from where we are conducting today this course. I hope Daniel remembers that he came here with Dr. Sunil Sharma, I think 2005 or 6, and he did 2 gastric bypasses here. Daniel is a great teacher, great human being, and I had some time at that time. I was in my postgraduate days and had time to interact with Daniel and saw his surgical skills. So welcome, Dan, again to this course and to the institute, where you did probably the first surgeries in India.
Thank you.
Next, we have none other than Professor Buchwald from USA, the teachers of teachers, and probably somebody who has taught all of the surgeons who are on this panel. Whose sagacity in the field of bariatric and metabolic surgery is something which is contribution beyond par excellence. He served as the president of the IFSO, ASMBS, and several other societies. A surgeon who is not only a pioneer who would have done more than 4,000 bariatric cases, but also the primary author of many meta-analysis in the field of obesity and in the field of bariatric surgery. He is the leading author for the articles in the American College of Surgeons guidelines for bariatric and metabolic surgery, and was the member of the board of director for the Scientific Review Corporation at the ASMBS. And he is highly recognized for publishing a lot of these articles, which we still follow today and learn from them. Served as a co-editor and the chief of obesity surgery from 2009 to 11. And in 2011, his surgical atlas on metabolic surgery and bariatric surgery was published. In 2019, he accepted a position with the American College of Surgeons to make metabolic surgery a nationally recognized entity. And I think nobody can be more successful than him. Dr. Buchwald also has authored over 360 peer-reviewed publications and more than written chapters and more than 100 books. So I think we are extremely, extremely blessed and honored to have Professor Buchwald here on this course. And I personally look forward to learn a lot from him during the entire course. And he has always helped me personally, and also not only in the field of bariatric surgery, but personally also for my problems. And he's always a father figure for us. So welcome, Professor Buchwald. and I'm so happy and so honored to have you.
Thank you, Mohak. Thank you.
Next, we have Professor Andriy Lavryk from Ukraine. Andriy is a PhD from Ukraine and a professor of surgery at the National Institute of Surgery and Transplant. He's a founder of Ukrainian Bariatric Surgery Society. A great friend. Andriy, welcome to this course. And we look forward to learn from you, to get your inputs, how to improve this procedure, and know more about this procedure. Next, we have Professor Rana Pullatt. I think I heard that Rana will join us later, but Rana serves as the Director of Robotic and Bariatric Surgery at MUSC, and he's a professor surgery in general gastrointestinal and bariatric. He's board certified by American Board of Surgery, actively involved in ASMBS activities, and also at this time, he is the president of the Carolina chapter of ASMBS. Rana is involved in several committees in SADI-S, which is premier organization in laparoscopic surgery, and he has trained many surgeons in innovative procedures. He serves as a director of bariatric surgery at VISN, which provides bariatric surgery for veterans in South Carolina, Georgia, and Alabama. He performed the first laparoscopic duodenal switch in South Carolina. So Rana, I hope you join us, and we look forward to have more insights from you on the procedure. Last but not the least, we have Amar. Dr. Amar Vennapusa is from India, and he's our own surgeon. He, I think, probably has published most articles from India on this particular procedure. He's a member of OSCE and IFSO, and he's interested in medical research, published several articles. But the important point is that all the work done on SADI-S has been done by Amar in the country. So Amar, welcome, and we look forward to learn from you on this course. Dr. Ugale, he is probably a teacher to me also. Yes, when we were in our yesteryears of laparoscopic surgery, when LabColi started in India, Dr. Ugale was the only one surgeon who went to every nook and corner of the country to teach laparoscopic cholecystectomy. He's a surgical genius, a very skillful surgeon, has done surgeries in many countries. He was the second surgeon to start laparoscopic ileal interposition after Aureo Di Paula, and he taught this ileal interposition to, I think, including me as a proctor, to many surgeons in country. He's a visiting professor at KLE University, Belgaum, and he has published many books and many articles. Dr. Ugale, warm welcome to you, and we look forward to have insights from you, to have your opinion, whatever you feel about this procedure, and to learn from you. Thank you very much for taking out some time and giving us this opportunity. Finally, Dr. Fobi and myself, we are co-directors of this course, and without much further delay, I would like to invite Dr. Ugale, Andriy, and Professor Fobi to moderate the lecture sessions. Thank you.
Andriy, go ahead. Dr. Lavryk?
Yes, I have a problem with Zoom. Sorry. And
You're fine. We can hear you.
We can hear you, Andriy. Just start. You can start to speak. We can hear you. Don't worry.
Okay. My greetings to all. At first, thank you very much, Dr. Fobi, for invitation to be here today. I am very happy, and it's horrible for me. Today we will talk about SADI-S operation, and this procedure was born in Spain more than 10 years ago by Professor Antonio Torres. Antonio Torres is one of the famous bariatric surgeons in the world. He was a IFSO president during 2011-2012. I am very pleased to invite for presentation about SADI-S, Professor Antonio Torres, please.
Okay, thank you so much, Andriy, for your kind introduction. And of course, in the meantime, I'm sharing my screen. I'd like to thank Dr. Bhandari, Dr. Fobi, for the opportunity for sharing this outstanding meeting with you guys. You know, my topic today is to talk about the update and long-term outcome of the SADI-S procedure. Here with some colleagues at Cottam, Henry Buchwald, it's going to be an honor to share with you my personal approach. This is my disclosure. My main disclosure is going to be this. I'm sorry, as you can see here, we at our department, we perform a sleeve gastrectomy, one-way gastric bypass. We perform SADI procedure, approximately 24-25% of our patients as revisional as a primary procedure. And you know, here you just have to remind the audience and you guys the way we perform our SADI procedure. We don't do a very important, a very restrictive sleeve. We put a bougie, a 54 bougie, a 18 centimeter bougie. We perform a dissection down the duodenum, following all the greater curvature. Our limited the pancreas, not the gastrointestinal artery, to get as much duodenum as we can, 3 centimeters, 3.5, and then we perform a tension-free duodenoileostomy. Here you can see as the ileum can bring it up, you know, very nicely without any tension. To perform, we perform a 2-layer hands-on anastomosis, even though you can do a staple anastomosis using a 30 millimeters staple if you want. But in this case, I have shown you our way of performing our duodenoileostomy with, you know, no tension. We use valve suture for performing this anastomosis at present time. Okay, so I think I'm sorry. Okay, this is the summary of our present experience with the SADI-S procedure. As Lavryk mentioned before, we started in 2007 performing our first 50 patient, 200 from the ileocecal valve. We moved in 2009 to SADI-S 250 because we have to reoperate some patient performing the anastomosis 200. And in this year, the same year, we started performing the anastomosis 250 from the ileocecal valve. We submit our first patient after failed sleeve to SADI-S. Now we are operating more than 550 patients, and we perform the first 50, 200. Then our standard is 250, and some patient with a lower BMI, a metabolic patient, we perform 300 from the ileocecal valve. It's one of the most important points of our experience is to maintain a very high percentage of follow-up. Now our follow-up is more than 70% of our patients. I'm very happy to hear because then Dr. Cottam will probably tell us regarding, you know, their follow-up going to be also increasing in their experience. This is our first approach, you know, comparing our data with the HES and HES. They're going to be long-term, 108 months after the operation, very stable. We know the exit weight loss was very stable, very uniform, even considering the different length of the common channel that he used to perform. This is our overimposed figure 7 years after our operation, you know, mimicking, you know, the experience of Dr. Hess. And here you can see our updated 10-year results. The say weight loss 78%, excuse me. The total weight loss 34, and regarding normalizing the BMI around 29. Regarding the metabolic profile of our patient, our 5-year result, you know, going to be very interesting. The remission rate is going to be in those patients that having oral therapy for their type 2 diabetes, 90%. Those patients under initially insulin, 47%, and globally 72% of global remission, considering no treatment, hemoglobin A1C less than 6%. And also we perform a study comparing Ruan-Y and SADI-S procedure regarding the way that the SADI-S procedure control the type 2 diabetes, monitoring the glucose variability 1 week, 7 days in a row in remission patient. You know, the percentage of growth of blood sugar less than 70 would be worse in the Ruan-Y compared with the SADI-S, and the percentage of patients with the normal range better in SADI-S, and the percentage of patients with glucose level more than 140 worse in the Ruan-Y. Probably going to be due to the preservation of the antropyloric area in the SADI-S patient compared to the Ruan-Y gastric patient. Recently, we revised, you know, the experience of Yuri Yasov in their experience. We revised comparing the SADI-S procedure with the standard Ruan-Y This is an open procedure performed with our Russian colleague, compared 226 SADI-S and 528 Ruan-Y, and, showing that long-term, 4 and 5 years, probably, the standard Ruan-Y going to be better regarding the total weight loss, the safe weight loss, the safe weight loss in those patients. But nevertheless, the protein deficiency and small bowel extraction rate was lower in the SADI-S procedure compared with the Ruan-Y. Duodenal switch. Ruan-Y might be more powerful, but more dangerous, in inverted commas, in this experience. Here you can see how, the safe weight loss at the beginning going to be even better for the SADI-S, but at the end of the day, it's going to be much better, in the duodenal switch, in the Ruan-Y duodenal switch. Long-term, regarding more powerful regarding the weight loss, but very similar regarding, you will see here, regarding the blood glucose level and the hemoglobin A1C long-term. Very similar, with no significant more than 3 years after the operation. This is a comparison between the standard duodenal switch, Ruan-Y duodenal switch, and the SADI-S procedure. What is the present situation of the SADI-S procedure after failure? Is going to be the most important scenario where we can use. It's a debate. We can do many things: banding the sleeve, plicate the sleeve, convert it to SADI-S, SAHI, classified partition, SASI, iliac interposition, or anyway. We recently updated our data regarding what is the role of the SADI-S procedure as a second step operation after a sleeve gastrectomy. And here you can see, our results regarding this issue. Here you can see 5 years after, with a very nice follow-up for a patient, how going to be the safe weight loss more than 75%, 77%, the total weight loss around 37%, and the BMI normalization of the BMI. Also, we look at the experience of the Deutsch, the Holland guys, comparing after failure sleeve, SADI-S and Ruan-Y, including a lot of patients, 74 Ruan-Y and 66 SADI-S procedure, and they observe how, the total weight loss in the Ruan-Y patient going to be very bad, comparison, or very not as good as after SADI-S procedure, 2 years after the operation. We also revised our experience with the Marion de la Cruz and Martin Busing in Germany, comparing the short and medium-term result of the SADI-S compared with the anastomosis gastric bypass. We observed, including in this experience, 42 patients with SADI and 42 patients with anastomosis gastric bypass. We observed a very similar result regarding the weight loss, but the symptomatic bile reflux was worse in the one anastomosis gastric bypass compared with our SADI-S patient. The same experience has been reproduced in our experience with the Qatar Hamad hospital there. We compared recently publishing of a study 3 weeks ago, the SADI-S procedure again, with the one anastomosis gastric bypass. We compared 42 patients with SADI-S and 49 with one anastomosis gastric bypass. And again, regarding the effectiveness of all procedure regarding weight regain was very similar, but SADI-S was associated with less upper gastrointestinal complication, and mainly, the bile reflux will be worse, although patients submitted to one anastomosis gastric bypass after failure sleeve. Regarding the nutritional issue, Dr. Cottam probably will share with us, their experience very similar to us, the complication regarding nutritional, also, regarding albumin, protein, and also micronutrients are going to be very, very well solved with a proper supplementation in our patient. All our patients have to be supplemented after SADI-S. Regarding the quality of life long term, the main number bowel movement in our patient is 2.5 per day, and only 15% patients are suffering more than 3 movements per day. Regarding the need of revisional surgery for regular hyperproteinemia, the total rate is going to be, when we analyze, we have 300 patients, 3.7, SADI-S 200 from the years of 12. This is the reason we moved to perform the anastomosis 150. We didn't have any reoperation in those patients submitted to SADI-S 300. What have we learned in the last 13 years? We started 2007. Well, we have learned that the selection of the candidate is essential. We have to minimize the risk with a proper preoperative preparation. The high protein diet before and after the operation will be essential. The supplementation is key in the success of the operation. The follow-up is essential, also is very mandatory by the dietitian, endocrinologist, and surgeon. And the replacement therapy in case of detecting any deficiency is crucial for avoiding more complication. Candidates to SADI must be informed about the procedure, how to be adherence, have to get the commitment of being, follow-up. If we observe a suboptimal adherence, probably going to be wise, very wise, to lengthening the common channel. They're going to be important in this scenario. But if the patient fails for finding this commitment, probably he or she will have some complication. So SADI-S at present time is currently our preferred technique for supermorbid patient, BMI around 50 or more, and very metabolic patient. And after failed sleep is our preferred procedure, except the patient is very old, very badly performed at the beginning sleep, or the patient present GERD or sleep stenosis, Roux-en-Y going to be our preference. All these decisions are going to be depending on the age of the patient, the follow-up commitment of the patient, and the supplementation implementation of those patients. And this is our up-to-date long-term outcome. Thank you so much for your kind attention.
Thank you.
Now I will stop sharing.
Thank you very much, dear Antonio, for a very interesting and important presentation. Thank you. But modern bariatric procedure is developing for one anastomosis in the operation and MGB or LGB, but few years ago, and Roux-en-Y gastric bypass is a gold standard in bariatric surgery. And now we change for one anastomosis bariatric procedures. It's very interesting about size of common channel after this operation for SADI-S or MGB. My question is, when we must use 300 centimeters? This is only for patients without difficult metabolic disorders, without diabetes type 2. When?
Well, we implemented 300 common channel if the patient is metabolic, but he or she, they are not very obese. I mean, if he or her BMI is around 40, 42, 43, 45, but very metabolic, we do 300 from the ileocecal valve. And also, after failed sleep, the patient is not very heavy and is very metabolic, we do 300. In the other cases, our standard measure is 250. This is the comparison, the Yuri Yasov experience also is 250, and there are some other. We are waiting for the result of the study coming from Canada. We are comparing after failed sleep, or we are comparing, they are finishing their clinical trial comparing 250 with the standard Roux-en-Y donor switch. But summarizing my answer to your question, going to be, we use 300 when the patient is metabolic but not very heavy.
Thank you. It's a very important part of SADI-S operation is to preserve the pylorus. What pylorus function after SADI-S? It's now dumping syndrome, now another complication. Pylorus is good function after SADI-S.
Yeah, I think it's going to be important. In my humble opinion, we don't know yet how important is the preservation, not only the pylorus, but also some antrim. This is one of the reasons we don't divide the right gastric artery in our surgical technique, because we think that, preserving the right gastric artery, probably we are preserving some vagal innervation on the lesser curvature of the stomach. And this vagal preservation can be important for maintaining the function of the pylorus and for maintaining, the gastric emptying control. We don't have, scientific data for that. But I'm saying that being more physiological, you will much more better. If we disturb, the lesser curvature, we can damage, this vagal nerve. But it's just, I admit this is just speculation. There is no data about that. But I think maintaining as closer as we can to the normal physiology of this area is going to be better for our patients.
But pylorus is a very important place in all gastrointestinal surgery. Thank you very much, Antonio.
So can
My
I
pleasure.
ask you one question here, Antonio? What is the lowest BMI that you have taken up a patient for SADI-S?
39.
Okay, thank you.
39.
So I think we can go on to the next presentation in our session. And this is to give you an insight into the Indian experience. And this is going to be presented by Dr. Amar. Amar is a young, very skilled, prolific surgeon based in Hyderabad in my city. And we are pleased to have him here with us. We are involved in some joint academic activities also. And Amar has been involved in ileal interposition surgery also. He is capable of doing and has been doing the whole wide variety of bariatric surgeries. He then had moved a lot onto the SASI procedure. And then we find he has shifted more to the SADI-S now. So we should hear from Amar his reasons for having shifted through all these different procedures and his data and the Indian experience. So over to you, Amar.
Thank you very much, Dr. Surendra. Thank you for introducing me. Thank you, Dr. Fobi and Dr. Mohit for inviting me to present the Indian experience. I'm sharing my screen now. Are you able to see the screen?
Yes,
Yes.
coming through clear.
This I'm talking about only primary SADI-S today. Actually, I do SADI-S as a revision surgery also. But today, because main program is about primary SADI-S, I'll be talking about this. So SADI-S is basically a loop modification of duodenal switch. If you see here, in duodenal switch, we do sleeve, we disconnect the duodenum, and we divide the ileum also, like 250 centimeters proximal to ileocecal junction. And the divided duodenum is attached to the ileum. And the separated intestine is attached 1 meter proximal to ileocecal junction. The difference between this and SADI-S is a loop modification. We do the same thing, like sleeve is here, duodenum is disconnected, but the ileum is attached in a loop fashion. So by doing so, food will be entering the 250 centimeters, bile juice, pancreatic juice, they will also be going there. Both will be traveling together for 250 centimeters. So the absorptive area is increased. So malabsorption risk will be reduced. If you compare these two procedures, if I divide the duodenum, this ileum here, and attach it here, that will become duodenal switch. That means I am just stopping one step before in duodenal switch to make it SADI-S. So as Dr. Antonio Torres has started this procedure in around 2007, they published article on SADI-S. They mainly kept 200 to 250 centimeters. Later, several authors published articles with different names, like loop modifications of duodenal switch, like one anastomosis duodenal switch, single anastomosis duodenal switch, sleeve gastrectomy with loop duodenal switch, stomach intestine pyloric sparing surgery. All these surgeries are basically loop modifications of duodenal switch. But in SADI-S, when they kept 200 to 250 centimeters, all these remaining procedures, they kept 300 centimeters as a common channel. So these articles, in IFSO position statement published in 2018 in obesity surgery, Wendy Brown et al., even Dr. Antonio Torres is also in that part. So they include all these studies. So there's one more modification of loop duodenal switch, which is called loop duodenal bypass with sleeve. So, but basically the difference is the anastomosis is duodenal-ileal here. Here the anastomosis is duodenal-jejunal. And the other difference is here the common channel is fixed at 250 centimeters, regardless of the total bowel length, or 300 centimeters, regardless of total bowel length. While in sleeve loop DJB, the biliopancreatic limb is fixed at 250 centimeters or 200 centimeters, regardless of the total bowel length. So it's just a proximal elevation of the anastomosis here. This is also part of loop duodenal switch, but mainly we'll concentrate on this side. So I started these surgeries in 2013. I started for lower BMI people, I started sleeve loop DJB. For BMI more than 50, around that, I started doing SADI-S. When I started initially, I kept 250 centimeters. Later, I moved on to, for some time, I stopped SADI-S because several people developed malabsorption with 250 centimeters in Indian settings. So then I started changing. I realized that it's not the problem with surgery, it's the problem with the common channel length. Then I moved to 300, 350 centimeters. Now I am doing a fixed percentage bypass rather than fixed length. I removed both surgeries. I started doing fixed percentage bypass, like fixed ratio bypass. So the data is I performed around 176 surgeries between November 2013 to November 2020. This is primary SADI-S, and revision SADI-S are around 34 surgeries, and sleeve loop DJB are 126 surgeries, and SASI bypass around 130, 140. So altogether, sleeveless bypass procedures I did around 500. So age group of these patients is average age is 40.2, and males and females are almost equal, 91:85. And 47.7% of the people are suffering from diabetes, type 2 diabetes, and 31.3 are having pre-diabetes. So if you see the weight and BMI changes, so initial weight was 125.4 and the BMI was 45.4. At 6 months, that has reduced to 86.3 kilograms, and at 1 year, 71.3. So the number of patients at 6 months are 161, at 1 year are 142. In fact, actually, this SADI-S is the primary surgery I'll be doing for most of the people, followed by SASI bypass, then sleeve. So if you take the BMI, 45.4 is the initial BMI, that has been reduced to 31.1 at 6 months and 26 at 1 year. If you see the long term, like 3 years and 5 years, the number of people who complete 3 and 5 years are less, like 31 at 3 years and 14 at 5 years. So it's fairly maintained. See, if you see at 1 year, it is 71.8 and 26 BMI. So here the weight is 70.3 and 68.7. The weight is still less here because most of all these 14 patients are with 250 centimeters common channel. So like BMI is 25.5 at 3 years, it's fairly maintained the same way, and 5 years also same. So if you see excess weight loss percentage and total weight loss percentage. So total weight loss percentage is at 6 months is 30.9, at 1 year is 41.4. If you see the difference between 2.5 meters and greater than or equal to 3 meters, actually I include all the people. Nowadays I am not doing 2.5 meters, I am doing only 3 meters or more than that. Even if you take fixed ratio bypass, the minimum common channel length should be 3 meters. So most of the people, it will be around 3.5 to 4 meters. So if you compare, I include all these patients with including fixed ratio bypass as well as 300, 350 centimeters common channel in this group. So if you take 2.5 meters group, it's 36 at 6 months. For greater than or equal to 3 meters group, it's 30. So at 1 year, it's 51.2 for 250 centimeters, and the second group is 39.4. There's a significant difference. So weight loss is very high if you keep 2.5 meters compared to this group. But if you take excess weight loss, it's almost similar. Like average excess weight loss is 74.3 at 6 months, 99.3 at 1 year. So if you compare both groups, it's almost similar. There's not much difference. If you go at 3 and 5 years, that's fairly maintained. Total weight loss is fairly maintained at 45.3, 49.2. But nobody with the second group reached 5 years. So still the total weight loss percentage is more for 2.5 meters group compared to the second group. But the excess weight loss is almost similar. There's no significant difference between both groups. But if you take the weight loss success rate, we define weight loss success rate based on percentage of total weight loss greater than or equal to 25, or we take percentage of excess weight loss greater than or equal to 50. If you take this, all these figures are above 90. So 100, if you take 2.5 meters, all years it's 100. It's like excess weight loss percentage also, all years it's 100. It's almost, the second group is closely matching. If you had 3 years, the number of people who completed 3 years are very less. So they are 100%. Like excess total weight loss percentage. So it's fairly good. So if you take the weight loss success rate, even if you increase the common channel length, it's not much affected because the biliopancreatic limb length is still very high. So even if in the second group also, below pancreatic limb length, average length is 4.5 meters. If you see the diabetes point of perspective, so number of people are 47.7%, as I told you. The mean preoperative HbA1c is 8.7, that has reduced at 1 year to 5.1. In 2.5 meters group, it's almost 4.6, that has reduced to 4.6. And the second group, greater than or equal to 3 meters group, it's 5.2. It's almost closely same. So that reduction is maintained over a period of 5 years. So if you take that remission is at 1 year, it's almost 90%. There's no difference between those both groups. It's almost same. So even if you increase the common channel length, diabetes remission point of view, it's not changed much. And that remission is maintained over a period of years. Like a number of people are only 7 at 5 years. So these are all 250 centimeters common channel people. And comorbid conditions are also like resolution is very high, like 77.6 at 6 months, 88.7 at 1 year for hypertension. For hyperlipidemia, it's almost around 90%. So these results are similar to those published by Survey et al. In 2020. It's like, sorry for the spelling mistake here. So if you take the complications, 30-day mortality rate was nil. None of the patients had a death rate. But greater than 1 year mortality was 3 people out of 176. 2 patients are 250 centimeters common channel. One is 350 centimeters common channel. 1 patient had alcoholic liver failure. He got addicted to alcohol. At 1.5 years later, because of liver failure, he died. Remaining 2 patients, one from 250 centimeters, one from 350 centimeters group, both had hypoalbuminemia. And because of that, complications developed in spite of treating them with amino acids and albumin, they didn't recover. Postoperative bleeding, intraoperative bleeding has only 1 patient had intraoperative bleeding while dividing the right gastric artery, but the patient recovered well. Postoperative bleeding occurred in 2 patients. Both I had to do re-laparoscopy and wash everything, but they recovered very well. 1 patient had sleeve leak, that's a localized leak. I didn't do anything, just I kept antibiotics and patient recovered well. There's no anastomotic leak. Anastomotic leak can be dangerous because bile will be coming out. So fortunately, anastomotic leak was nil. So I used, as Dr. Andriy was telling, I used 2 layers, outer layer and inner layer. So even though 1 layer is enough, I prefer to use 2 layers so that, and I prefer to cover that with momentum so that leak risk will be reduced. If you see the hypoalbuminemia, I'm showing at 6 months and 1 year. If you take 2.5 meters, in Indians, at 6 months it's 25%, at 1 year it's 40%, when you take albumin as less than 3 grams per deciliter. So it's like a moderate hypoalbuminemia, you can say. So 40%, so significantly very high. When I increase the common channel to greater than or equal to 3 meters, that has drastically reduced to 7.1%. The difference here is compared to foreign people. Dr. Antonio is using 3 meters, 2.5 meters as standard, but some people have 3 meters. But in Indians, they cannot tolerate this much short common channel because Indians, even though they are non-vegetarian people, they take only weekly once in spite of insisting them. So if I keep less common channel, people are landing in trouble. That's the reason why for some time I stopped doing this surgery. Later, after starting SADI bypass, like Dr. Surendra was telling, like initially I was doing this surgery, shifted to SADI bypass. SADI bypass, because it's a partial bypass, it's also a modification of duodenal switch, but that duodenal route is open. So thinking that partial bypass will reduce the complication rate. But later I realized that there's no difference. It's not the problem with the surgery type, it's a problem with the common channel. So I started increasing the common channel to 300 to 350. In spite of using 350 centimeters, some people developed severe malabsorption. All this 7.1% where malabsorption, this hypoalbuminemia was there, all people, I started measuring the total bowel length since 2016. So all these people have more than 55% of the bowel bypass. That means even with 350 centimeters common channel, when you bypass more than 55% of bowel, that is below pancreatic limb length, if it is more than 55%, they are landing upon troubles, like significantly high risk of malabsorption. So after realizing that, I changed to fixed ratio bypass. Like I'll restrict bypass the total bowel to 55%, not more than that. If anyone is having severe like diabetes, I'll keep 55%. If they are vegetarians, I may reduce to 45 or 50%. Like that, depending upon the age factor diabetes present or not, initial weight like that, I will keep it 55, 50 or 45. So I started doing like fixed ratio bypass for the past 1 year. So none of the people had any hypoalbuminemia after changing that practice. If you take bowel problems, the main problem with the SADI-S or this low duodenal switch procedures is steatorrhea, foul-smelling gas, and incontinence and diarrhea. So these problems, you see, if you see steatorrhea, it's 80% at 6 months, and 1 year is 66.7%. It's actually reduced from 6 months to 1 year, but all these problems are triggered when the patients take oil food or if the food contains spice and chili items. So if they avoid them, the problem has drastically reduced. So we always counsel people not to take these, and if they take these, this is going to be the problem. And surprisingly, some patients had constipation also, especially when the common channel length is 3.5 meters or more than that. So if you take vitamins and mineral deficiencies, at 1 year if you take, vitamin B12 and all the patients are advised to take high dose bariatric multivitamin supplements. So we got them separately prepared for bariatric purpose. So vitamin B12 and D actually in fact increased compared to the preoperative values. Most of the people have deficiencies of these two, and they have increased because they are taking supplements regularly. While vitamin A is reduced in spite of taking supplements, some people and they have to get the test done every 6 months. All the vitamins have to be checked for them. Iron is same, but calcium is also reduced. So other problems, if you take dumping syndrome, I'm talking about symptoms. It's not like confirmation. Dumping syndrome and marginal ulcers and stump leak, reflux problem, internal hernia. None of the patients have these problems. Survey et al., they published a multi-centric study in 2018. In that also, all these problems are less. So these are initially when I started with 250 centimeters, this is called fixed common channel. Like I fixed the common channel at 250 centimeters, 300, 350 centimeters. 26 patients are 250 centimeters. I stopped doing that. 300 or 350, that's 16 patients, 300. 1 or 2 patients are 350. And after changing to fixed ratio bypass, so this is actually initial part when I was doing. I kept 60% bypass for 3 people, but I stopped doing that after realizing that more than 55% is causing problems. This is the common channel percentage, not the below pancreatic limb percentage. It's 40% means common channel, below pancreatic limb is 60%. So here the common channel is 45, below pancreatic limb is 55%. So most of the people have 50% bypass. One patient where there are no comorbidities, I kept 55%. If you see the mechanism of this surgery, actually this is the method. I divide right gastric artery for all. That's a deviation from what Dr. Antonio has described. I divide this. This makes the anastomosis easier. Like this sleeve, pyeloidecantrum, pylorus, and first part of the duodenum, all are freely mobile, and they can be actually brought into the infracolic compartment, and you can anastomose with the ileum. So regarding the pylorus function in this case, some of the, we will preserve the left gastric vascular arcade. Some of the branches of the vagal branches will come through nerves of lateral jet. They'll be supplying this. There may be some compromise of the function, but none of the patients had symptoms in spite of, because this will keep in a straight line. So they didn't complain any of the symptoms. So how it works, it's not because of restriction or malabsorption, it's because of the hormonal changes. Because of doing sleeve, ghrelin will come down, ghrelin will come down, and food is directly going into the ileum. So GLP-1 peptide hormones will increase. Ghrelin is a hunger hormone that's coming down, and GLP-1 peptide hormones are hunger suppressing hormones, and they are increasing. So because of the hormonal changes, these hormones will be controlling the total body fat. Because of the reverse hormonal changes, the fat set point will be reset to a lower level, and the people will lose weight. Similarly, these hormones will be affecting the insulin also. Ghrelin acts against insulin. When ghrelin comes, insulin levels will increase. GLP-1 peptide hormones increase insulin production and insulin sensitivity. So because of the hormonal changes, which are maximum, that mechanism will be working like highly effective surgery. And there is a diversion of below pancreatic juice, like up to 4.5 meters, even in spite of keeping 3.5 meters. Average bowel length, what we observed is 7 to 9 meters. So even if I keep 3.5 meters, I am bypassing around 4.5 meters. So by bypassing significant length compared to gastric bypass and mini gastric bypass, so the surgery power is more. And because of the preservation of pylorus and first part of the duodenum, that malabsorption is risk, because that will allow bypassing more percentage of bowel without much problems. So advantage, sir, there's no risk, at least gastric remnant. pilus is preserved, so dumping is less. And reduced risk of anastomotic complication because it's only one anastomosis compared to duodenal switch. And internal hernia, because I divide the right gastric artery, there's a big space behind the sleeve, duodenum, and this anastomosis. So even if the intestine goes here this way or that way, it won't get blocked. And the marginal ulcers, they are less because the bile will be neutralizing, this acid will be neutralized by the bile here. And there are more hormonal changes. But one point here is, if I am doing it as a revision, 300 or 350 centimeters will not work because some people, I have mixed results. Some people didn't lose much weight, even though they lost, but they are not up to the mark. So for revision, I always keep 250 centimeters. I don't reduce the size of stomach again. I'll just leave the stomach like that only, but I'll keep 250 centimeters as a revision one. And surprisingly, those people don't develop malabsorption because this stomach is more, they can take more food. And problems are the access to the biliary duct is gone. So if anyone develops gallbladder stones and if they come out and block here, the only option is surgical intervention. So I'll keep all the people on orthodeoxycholic acid for 1 year, 1.5 years. So that if anyone develops stones, even if they are asymptomatic, I'll remove the gallbladder. If already they have stones at the time of surgery, I'll remove the gallbladder at the time itself. But the risk of gallbladder stone formation is less here compared to SASI bypass. Wherein SASI bypass, this is not disconnected, duodenum is not disconnected, only anastomosis to the ileum. So both channels are open here. So malabsorption, that stone formation risk is high. But common channel, if you keep 250 centimeters in Indians, it's going to be a problem. I'll just show a 2 minutes video of how I do. So this starting with opposite to insula angularis, I keep 4 ports. So I use either a harmonic or ligature. So the dissection behind the duodenum is very important. So from behind, I can divide that beside layer, thin layer, and I'll mark this beside the first part of the duodenum. So some part of
your video is not playing.
Sorry?
Your video is not playing.
Not playing, okay. I mean, is it coming in breaks or it's not at all?
It's not coming at all.
So
okay.
We have publication like it's already accepted for publication in World Journal of Laparoscopic Surgery. It's coming. It will be coming this month. And I conclude here like it's very good surgery in terms of weight loss and diabetes remission. And advantages are no risk, no at-risk gastric remnant, less dumping, and pilus is preserved. But the problems are no access to the biliary tract. Malabsorption can be high if you keep 250 centimeters in Indians, and dissection will be difficult. On we need that training is required for that. Thank you very much.
Okay, Ugale.
Thank you very much for your presentation, Amar.
Maybe Dr. Fobi, we can ask him some questions because I think he's having some problems with his network. That's not. Or maybe we move ahead to the next lecture and then we ask him questions. What do you say?
Yeah, let's move on. Let's move on to the next presenter, Dr.
Daniel Cottam.
For you are that is
Yeah.
Yeah, I'm
Surendra,
ready.
we're having a problem. You're having some technical problems, so we're going to move on, and then during the panel discussion, you can ask some questions. Is that okay?
So that's fine.
Yeah.
Can I quickly ask
Okay,
him?
go ahead now. I can hear you now. Go ahead.
Yeah, so Amar, in spite of the fixed ratios that you're using for the bypass, do you still find a problem with malabsorption or malnutrition in patients?
No. Actually, when I restricted the bowel length to 55%, like biliopancreatic limb to 55%, not more than that, I didn't find any malabsorption. So, but I don't use 55% for vegetarian people. I restrict to 50% only for vegetarian people. For non-vegetarian people, up to 55%, but not more than that. So I didn't find, actually, all the data I have been collecting, but the number of people who underwent the fixed ratio bypass is only 32 so far. So we don't know, like if you, like long term, you need to check. So this is the ratio I'm using it now, either 55, 50 or 45. I think again he got poisoned.
Okay, let me ask you, said 55%. Do you make a requirement that the common length should be at least 300?
Yeah, it's minimum 300. So It's
And
not 250. Minimum is 300. The mandatory.
you do measure the complete bowel length in every operation?
Yes, I measure.
Okay. All right. Thank you. All right. We'll move on to our next presenter. Daniel is a good friend. Known each other for years. He's an excellent surgeon. He moved on from the sleeve to the bypass, and now he's doing the SADI procedure. Interestingly, I just found out that he did the first gastric bypass on our campus here in Indore, and we're glad to have him back. And so, Daniel, go ahead and share your experience in the United States with the SADI operation, which is getting more acceptance in the United States.
Yes, thank you very much, Mal. I repeat all those kind words, and these are my disclosure slide. And this is actually a spider that I saw just the other day when I was out hiking here in Utah. So get the scary stuff over. I'm going to be speaking exclusively about our SADI experience here in the USA, and building on some of the great presentations we just heard. You know, I'm going to start off with my Indian experience as well. We did the first gastric bypass, Dr. Sharma and I did there at Dr. Bhandari's institution. And there's the first weight reduction surgery right there in Indore with Dr. Sharma. And there's our patient, and Dr. Sharma and I did it. Dr. Sharma was actually the operating surgeon. I was assisting him, but it was truly a unique experience, and I'd like to have my little portion of Indian bariatric history there. It was truly a fabulous opportunity to go over there and do that with them, and you know, I was just part of it. As you know, this would have taken off with or without us, but I was just happy to be part of the first one. So I'm going to give you a little bit about my history. I was doing gastric bypasses from 2002 to 2012. I try to forget my history about my band surgery, although we did several thousand of them. From sleeve, we continue to do those, and from 2007 to the present. And we started doing Roux-en-Y duodenal switches for 2 years, from 12 to 13. And it was in 2012, I saw Dr. Torres' paper and then his second paper, and we made the switch over to it. And after doing the first 10 of those, I said, there's no reason to ever do a Roux-en-Y duodenal switch again. The patients were doing too good. Dr. Rosal and I were coordinating on this when we decided to do the first one of these. So I ended up doing the first one, and he did it shortly thereafter. After accumulating about 50 cases, I got the opportunity to present at Dr. Phil Shower's meeting. And there was such a interest in how to do this operation that I was instantly asked by Medtronic to start doing courses for this procedure in 2015, and I have been doing courses up and until the pandemic happened. One of the biggest things for us in the US was not only the IFSO statement saying that it was a standard approach, but the ASMBS statement. And as an illustration of how far this has come and how quickly this has come, now we have insurance companies that have approved this as a primary procedure. And as a matter of fact, I'm meeting with one of the biggest insurances in the USA here very shortly about making it a standard approach across all their sites in all the states of the country. And then the latest milestone that we've hit with this operation in the United States is now this is actually being done as an outpatient procedure. It's become that common around the country. I've trained almost 200 surgeons in the US to do this procedure since 2015, and almost, I would think, 60 or 70% all the major institutions now in the US doing. And I mentioned in Texas, this is being done as an outpatient, and we do it as an overnight stay in a surgical center as well. So I'm going to talk mainly about our long-term results in terms of a 6-year outcomes from 2013 to 2019. This is a picture of us in some of the national parks, the Zion National Park. When this craziness gets over, I'm showing pictures from Zion National Park here. If you guys have the opportunity to come see it in wonderful Utah. And this is my son there on the right, and this is him rappelling down into one of these tiny little canyons that we have here in Utah. So this is a retrospective analysis of our first 750 patients and of 3 surgeons at 1 US center. We're now over 1,000 patients of primary SADI-S. And I just want to take a brief minute and say, we do sleeve gastrectomies and we do SADI-S's in our practices, and we really don't do anything else outside of a large revisional practice. We do about 50% sleeve, 50% SADI, with most of our SADIs being 300 centimeter common channel. If you look at this paper, which was published not that long ago, there were 750 with the average age of 49, but our average BMI was actually 50. So we're not skewing on the low side, and I think that's important to mention. These are all, by and large patients. And you can see from our preoperative comorbidity conditions, specifically the diabetes at 40%, these are not well patients either. So, and if you classify people in terms of high risk and low risk, what you'll see is that 22% had BMIs over 55 and 13% had age over 65. So this is not a low risk population, despite the fact that I'm in a private practice situation. The important thing, and I think this was brought out by Dr. Amar's complication data, but you can also see this when you look back at our paper when we compared this to gastric bypass and regular standard DS, that the short-term complication profile for this approach in weight loss surgery is unbelievably low. And one of the things that I always like to point out, it's not because of the skill of the surgeons per se that it's unbelievably low, although that plays into it. The truth is that it's just an easier approach healing-wise, and so patients have fewer problems. So when we look at our 30-day return to the emergency room, it was only 0.4%. The readmission rate was only 1.1%, and the reoperation rate was only 1.1%. And the most common reason was intra-abdominal hematoma. I mean, if you look in the literature even now and the MISQUIP database, and what you're finding is that there's about a 0.5 to 1% reoperation rate for bleeding issues around the world. And so we're also part of that cohort, so we do have that, and that's the most common reason. Our short-term complication rate overall is 7.8%. And I think if you look down here at the bottom, and the thing that I've highlighted in the right is what we're really worried about according to Clavien-Dindo classification is class 3, class 3A, 3B, and class 5, which are returns to the operating room. And what you see is kind of what I said, is the intra-abdominal hematoma was the most, and the postoperative bleed, and everything else was very, very, very small. And that's what you would expect with this, this approach. And I need to bring out the very important point that these were all primary SADI-S's. These weren't revisions. We tried to keep those separately because, as you know, whenever you add a revision, there's no way to have the same complication rate. When we look at our long-term complication rate, and this is what I wanted to really illustrate, it's 11.7%. And that is amazingly low if you consider that with the long-term gastric bypass data and the long-term DS data, what you're really seeing is much higher than that, by sometimes double and triple the amount. In our own practice, we saw a decrease of 350% in the complication rate when we compared them side by side. Now, when you're talking about complication rate, it's always not what the percentage, it's really what you're including in that long-term complication rate. And if you look at us, we're including cholecystectomies in that long-term complication rate. And if you look at that 3B complication rate for reoperations, what you're going to find is that 4.4% also includes 6 cholecystectomies. So I want, that's not that high. We did have 3 deaths. We only had 1 perioperative death from a small bowel intestinal leak. That was truly a unique and strange incident. We don't need to go into it, but it's just unbelievably rare. And we had a various smattering of things. And if you really want to dig into that, you can always pull the paper that this is all pulled from. But very, very low overall complication rate. And if you, like I said, you get rid of a lot of the other things. The other complicated, what you find is very low. And, you know, for 750 patients, you know, I think it's important when you look up at the very top box up there at diarrhea, we only had 16 patients for the whole time that complained of diarrhea. And I will tell you that, Dr. Amar brought this out, that we have quite a few patients that complain of constipation. So it's not unheard of, despite the fact that you would think that that would be impossible with this operation. When we look at the weight loss outcomes, as I said before, our starting BMI was 50, and we have a 300 centimeter common channel in the total publications. Now, both Dr. Torres and Dr. Amar brought out very important points. I'm not so dogmatic about the 300 centimeter limb lengths. However, I will tell you this, is that for people who are lighter BMI, I will go up to 350. And for people who are BMIs over 55 lately, we've been getting their consent to go to 250, and we've had several people choose that approach as well. We don't have the problems with protein intake as India has, so I'm not trying to compare them exactly, but as you can see, the weight loss outcomes for the BMI that go from an average of 50 to 32. And when you, whether you look at total weight loss of 35 or excess weight loss of 75, that's still very good. Now, when we look at the nutritional outcomes at 6 years, this is a really important slide, because one of the things that people don't understand is that you can nutritionally replete these patients. So we don't delay people's surgery because we find preoperative vitamin deficiencies. And as has been brought out in Dr. Amar's slide, and Dr. Torres mentioned this briefly, you know, you find a lot of people with vitamin D deficiency preoperatively, but with education and supplementation, both vitamin B1 and vitamin D improved long-term. Now, the other things that you see up there, the ferritin, the triglyceride, the cholesterol, diabetic, you really wouldn't be surprised at, but vitamin B1 and vitamin D. One of the most important things about the iron levels is just getting people to take that. If they'll take it, we find that the absorption is very easy. When we mean improved and not significantly, there was no significant change, but we had 0 defects in vitamin B12. Now, these are significantly worsened, but that's statistically. Clinically, we didn't have any problems with any of the calcium, PTH, albumin, total protein, or vitamin E. I will bring the big caveat that we found is zinc. So we went from 0 deficiencies preoperatively to 18%. Vitamin A and K, what we found was they did get worse, but not significantly, statistically significantly. But when you look at the paper, you see they did get worse. But again, in 6 years, we had 0 patients that became symptomatic from a vitamin deficiency. And that's with the 300 centimeter common channel. So I understand people's fear about malabsorption, but honestly, we just did not see that reflected in the vitamin data. Now, we brought up a big deal, and I think it's really true when we talk about the SADI, the type 2 diabetes resolution. And, you know, Phil Schauer, for very good reasons, when he brought out the gastric bypass and was talking about the diabetes resolution. However, in his famous paper, what we saw with is the hemoglobin A1C less than 6, with or without medications, they were only going at about 30%. If I use the same definition on my SADI patients and say a hemoglobin A1C less than 6 with or without medications, I'm at 97% improvement. And I always tell people, if your goal is to treat diabetes and you have a patient that's here because of their diabetes, you know, with my knowledge and this kind of data, I think it's unethical to offer them anything else. I mean, 97% improvement, of course, a 30% improvement. You wouldn't go into your oncologist for a cancer and they would tell you, well, I can give you the treatment that fixes you 30% of the time, or I can give one that fixes you 97% of the time. I think I feel more comfortable giving you the 30% treatment, right? That would be unethical. And this is what I think about people who are coming in for diabetes. The second thing I want to mention about the SADI-S that hasn't been mentioned today is this effectiveness for GERD. Now, if you look at the GERD, what we found is that we had 30% essentially people who had GERD preoperatively. And if you take those 30% and break them down, what you find is that 53% of those people got rid of all their GERD postoperatively without a hiatal hernia repair, I might add, okay? And then what we had is 22.6% who improved and 15% who had no change. And we really don't mind if someone takes proton pump inhibitors. We don't think that's a failure in any way, shape, or form. And then people who fail proton pump inhibitors postoperatively will come back and do a hiatal hernia repair as a second operation. We really don't like to combine the operations. If it's bigger than 4 centimeters on a preoperative endoscopy, we've now started to just either fix those simple ones at the time of surgery, but anything bigger, we fix it a separate operation. We just found that our complication rate was too high. So that's the point. Now, I can't say, as Dr. Amar, that we have a 100% success rate. I wish that was true here in the United States. However, this slide, what I'm trying to do is show the differences in long-term failure rates between the procedures based on the data that we have out in the literature. And, you know, if we ignore the adjustable gastric banding, since it's not really being done, and you compare it to the SADI-S, what you find is that for sleeve gastrectomy, you get up to a 50% failure rate. That's pretty, you know, whether, and I admit that when you're talking failure rates, you really have to say, how are you doing it? Total weight loss, excess weight loss, comorbidity resolution, but this is just based on 50% excess weight loss. And so what you're seeing is that they have a range between 30 to 50% for sleeve gastrectomy. And for Roux-en-Y gastric bypass, it's between 14 and 35%. But what you're seeing with this SADI-S is somewhere between 13 and 17%, which is far less. And I look forward to Dr. Amar publishing his data so we can have one up there that says he has 100% to 17%, which, you know, my point with the SADI-S, and Dr. Torres brought this out beautifully with his first papers, is that the consistency of outcomes exceeds everything else. And, you know, Dr. Amar went into this beautifully about the importance. This isn't a malabsorptive operation. This is a metabolic operation. And it has to do with the bile salts and the hormones. And, you know, we're in the process of writing a beautiful review paper. And the whole point of the review paper is to get away from the idea that this is a malabsorptive operation. This is a metabolic operation. And the reason for long-term success is not the bougie size, because as you can see, Dr. Torres uses a 56 French bougie. I use a 40 French bougie. Our outcomes are exactly the same. And one of the most beautiful things that you see when you talk about going from sleeve to DS is that the outcomes are the same, despite the fact that it's many years later and the sleeve size has become accommodating. So, I mean, it's a wonderful thing. I will take some time to spend some things about the diarrhea. What we found in our practice, and if you decide to start doing this in your practice, almost all the diarrhea seen post-operatively is carbohydrate intake related. And if you can stop people from taking carbohydrates, now granted in India, that's going to be a bigger problem than it is in the US, but the truth is that when you create these long biliopancreatic limbs and rather short common channels, what you're going to find is that they don't have a fat malabsorption, they have carbohydrate malabsorption, and that's what's feeding the diarrhea and the steatodiarrhea and stuff like that. Well, how we treat that is usually probiotics, over-the-counter meds, Lamodal occasionally, and occasionally activated charcoal with Gas-X. And those are a couple of little caveats that I get for people that are starting out on this operation. The post-operative diet in the US, what we try to do is what I call the low-carb lifestyle, less than 100 grams of carbohydrates a day, and more importantly, a very high-fat diet. And protein as well. We've done this on on numerous people who are vegetarians, and I'd really encourage Dr. Amar to publish his data as soon as possible, because we need the insight from a large population of people who are not protein or not carnivores, in other words, and how they respond and the technical pearls involved with that. So in conclusion, I'd like to tell just that SADI offers very good treatment of both morbid obesity and its comorbid conditions. And as you can see in our data, and our data is mirrored by many other people, the short and long-term complication rates are less than every RU limb-based approach. And with that, I want to thank Dr. Bhandari and Dr. Fobi for the opportunity. And I'll open myself up to questions. Unfortunately, I can't hear Dr. Fobi now.
Yeah, I was muted. I don't know why. Do you measure the whole length of the small bowel routinely?
No, I do not. And after listening to Dr. Amar and Dr. Torres, I think it's something that I really should start doing, not because it's going to impact, at least in the short term, but I think a more individualized approach, much as Dr. Amar is doing, is probably indicated. And, Dr. Hess did his data based on percentages, and I really think that's going to allow us some type of a formula between the patient's BMI and the patient's overall limb length needs to be achieved for some that balance between too short and diarrhea. And then the other thing that you really have to ask yourself is that what's the acceptable rate of revisions for this for protein malnutrition, right? And I think, Dr. Torres in his first paper was beautiful. At 200, he had 100% success, but he had an 8% revision rate. Now, overall, that's not so bad, but he went to 250, but then again, their success ratio went down, and I'm at 300. My success ratio is slightly less than that, right? And so is that what level of common channel length are we willing to tolerate in terms of revisional operations for this? Because, I can get 100% too, I think, if I went shorter, but I'm not quite sure. And when I started this, I did want to be on the edge, because as the first person in the US, whenever you're doing that, as you know, Mal, you're sticking your head out there and you're saying, cut it off. And so I didn't want to be on the edge with that. So we picked 300. I don't know if it's the right, I don't know, so I'm admitting up front that I probably should be measuring the total bowel limb length for future considerations to try to figure this out to a more individualized approach.
Okay, I'll let Dr. Bhandari go on with our next presenter, Mohit.
Okay, thank you. Thank you so much, Dan, for your fantastic lecture. Always a pleasure to hear. Now I have it's a very important part of the meeting. I would like to involve and invite Professor Henry Buchwald for his lecture. I have already introduced Professor Buchwald, who does not require any introduction, but Professor Buchwald, we look forward to have insights from you.
Thank you. Wendy, can I have my slides?
Yes, yes.
Okay,
Okay, we have your slides now.
Good. Well, thank you for asking me to speak. It's a privilege. It's a pleasure. And you called me a sage. I'll try to be sage-like. May I have the next slide, please? I think it's important to know a little history. And let's go back to 1953, when my associate friend, Richard Varco, did the first operation for weight loss, first bariatric, metabolic bariatric procedure. He did 2 anastomoses. He anastomosed 40 centimeters of jejunum beyond the ligament of Treitz to 4 centimeters of ilium. And he did this to prevent any reflux into the ileal segment. He didn't publish his case. And that's the Varco procedure. Go back to the first slide. And in 1954, Kremer Lanier, same institution, University of Minnesota, published in essence the Varco procedure. 1969, Payne and DeWind came up with a single anastomosis modification, namely 14 inches, and mind you how short all this is, 14 inches beyond the ligament of Treitz to 4 inches of ilium end to side. And in 1971, being a good student of Dr. Varco's, I pushed the 2 anastomoses operation. I think I did about 1,000 of them. Next slide. So there is the original Varco with a separate anastomosis of the bypassed bowel to the cecum. Next slide. And there's the pain and DeWin modification. Next slide. And I went right back to the Varco procedure. Next slide. So in 1975, Bill Scott, who was chairman in Vanderbilt, said, you know, we can have a randomized trial. And he did. He operated all the cases. He randomized them to end to side, end to end, 2 anastomoses, 1 anastomosis. He found absolutely no difference. So I put this in as a historical background. Next slide. Now we come to the biliopancreatic diversion. The Scopanaro, the late, wonderful Nicola Scopanaro procedure. It was a hemigastrectomy, 2 anastomoses, a roux gastrogenostomy, and jejunal-ileostomy to form the common channel. And we've been talking about the length of the common channel. The Scopanaro operation, the original, had a 50 centimeter common channel. Next slide, please. And there is the original Scopanaro operation. Next slide. Now, when the operation crossed over the Great Pond to this hemisphere, the first one who made the adaptation in 1993 was Marceau in Montreal, Canada. He substituted a sleeve gastrectomy for the gastric, hemigastric resection. He cross-stapled the duodenum, had 2 anastomoses, the duodenal ileostomy and the jejunal ileostomy to form the common channel. His operation failed. Why? Because the duodenum doesn't hold staples very well, and they all opened up. So Hess in 1998 did the same procedure, but divided the duodenum after he did his sleeve gastrectomy, and that succeeded. And that became the modern DS, or what's been called biliopancreatic diversion, DS. Next slide. So here is the Marceau operation with the staple duodenum that failed. Next slide. And here's the Hess and Hess operation, 1998, very late, with the divided duodenum. Next slide. So now we go on to what we're talking about today, the SADI-S. And the first paper was by Sanchez Pernot in 2007. And of course, the senior author and the man behind all this is our Antonio Torres. Now, the modification was a sleeve gastrectomy, same as the others, division of the duodenum, same as the others, but now 1 anastomosis. A duodenojejunostomy to drain the stomach and the first portion of the duodenum and concurrently construct the common channel. Next slide. And we've seen this slide many times now. Next slide. So let's look at these differences. And I continue to put in the biliopancreatic diversion because there are differences. Gastrectomy, biliopancreatic diversion was a hemigastrectomy. DS, sleeve. SADI, sleeve. Duodenal division, first portion. Gastric drainage for the biliopancreatic diversion, a roux jejunal-ileostomy. For the DS, a roux duodenal-ileostomy. And for the SADI-S, a loop duodenal-ileostomy. The jejunal-ileostomy, end to side, and for the SADI, none. Common channel, 50 centimeters, and DS and SADI-S, we're talking about variable, but usually these days 200 to 300. And finally, the duodenal ileostomy, the characteristic 1 or 2 anastomoses, Biliopancreatic diversion, none. Jejunal-ileal, the roux, and the SADI-S, the loop. Next slide, please. Now, based on these anatomical differences, are there potential metabolic neurohormonal differences, and why? I so agree, and it's been my lifetime work to tell everybody none of these operations are basically restrictive or malabsorptive. We're creating a metabolic milieu to correct an abnormal metabolic milieu. Bariatric surgery is part of metabolic surgery. We don't know exactly what we do. We know GLP-1 goes up, GIP goes down. We know all these things, but we have no distinct formula, no distinct equation of what we do with any of our operations. And we hope that we will do this in the future. And it'd be nice if our internist friends would help us rather than fight us. So let's look at the potential metabolic differences in gastrectomy. Well, the biliopancreatic diversion was different. The left and right upper vagi are intact. And as we now know, afferent impulses dominate 90% of the vagal impulses. When I was in medical school, we only learned that the vagus tells the stomach to secrete acid and pepsin. But 90% of the vagus gets signals from below going to the hypothalamus. The left and right lower vagi are divided, and the upper gastric hormones are intact. Now, when we get to the DS, or the BDDS, the left vagus is cut, it's gone. The right vagus, however, is intact all the way, and the lesser curvature gastric hormones are intact. The SADI-S, the same thing, because it's another sleeve gastrectomy. Now, the duodenal division is very high up. So basically, no food reaches the duodenum in any of these operations, which is important because it's been shown that when the food reaches the duodenum, you get secretions of GIP and other hormones, and this makes a great difference in terms of particularly diabetes. Now, single anastomosis versus dual anastomosis, does this make a difference? Proximal jejunal segment is devoid of food in the biliopancreatic diversion. Same with the DS. Now, the SADI-S is somewhat different. You can have some reflux, possibly, into the biliopancreatic segment from a loop. And you can have possibly, even though you have an attacked pylorus, you can have some biliopancreatic secretions going back into the stomach. And in all these operations, we are doing one other thing. We are dividing bowel. And there is a syncytium of nerves in the submucosa from the esophagus to the anus. Now, this syncytium of nerves must be doing something. In addition to going up to the hypothalamus via the vagus or the sympathetic impulses going by the celiac axis, they must be communicating. They must be telling each other something. And when we divide them, and we take a piece of bowel from below and bring it up higher, we must be interrupting that syncytium. And I don't know what it does. And this is something we haven't explored yet. Next slide, please. Winnie, can I have next slide? So what are the surgical advantages that we've heard of the SADI-S? Shorter operative time, single anastomosis rather than two. Decreased opportunity for anastomotic complications, a leak. If you do one less anastomosis, you have one less chance for a leak. And the construction seems to be more favorable in terms of avoiding internal hernias. Next slide, please. Now, I looked into the literature and I looked at a lot of papers, and I picked 4 as illustrative. Here is one paper, and I can have the next slide, please. Next slide, please. And this is a paper by Vieira in 2019. And the conclusion is that there is a difference between the SADI and the ordinary duodenal switch. There is a difference in the levels of GLP-1, glucagon, and insulin. So there is a difference. This single versus dual anastomosis makes some sort of a difference. Next slide. And here's another paper that, again, next slide for the summary. Again, from the same group, and they came to a conclusion that amino acid absorption is different. So protein absorption is different, favoring the SADI. Next slide. Well, when we first looked at things, before we looked at metabolic parameters, we were always concerned with two things: weight loss and complications. And there's so many papers out there now on weight loss and complications. And here's one by Topert. Next slide. Slide, please, Winnie. And basically, there is no difference. The weight loss, give or take here and there, is the same between the two operations, and the complications more or less is the same between the two operations. If there is a difference in weight loss, it has nothing to do with the single or dual anastomosis. It has to do with the length of the common channel, which is a metabolic effect. Next slide. And here's one more paper I looked at by Moon. Next slide. With the same conclusion. Next slide, please, Winnie. Winnie? Next slide, please. Same conclusion, that there is really no difference. Okay, let's go on to an analysis of what all this means. Next slide. So let's look at safety. Simplicity has its advantages. If you have a shorter, simpler operation, you benefit the patient. I mean, that's an adage that's long been known. If you have a shorter, simpler surgery, it expands the opportunity for surgery. Other people will get into the field. And if this happens, we will be helping a greater amount of people than 1% of the population that could benefit from our surgery. And a shorter, simpler expands the discipline of metabolic surgery. More people are aware of what we can do with metabolic surgery. But I'd like to also say that simplicity has its disadvantages, and we've seen those. The shorter, simpler surgery brings less skilled surgeons into the field, which increases complications, increases leaks, and does not benefit the patient. Now, today, we've heard only from master surgeons. They don't have many leaks. I did 400 DSs. I never had one leak. But there are people today who have leaks. And the best example is sleeve gastrectomy. When we did sleeve gastrectomies as part of a DS or part of a SADI, we don't have many leaks. But people are having leaks like a cottage industry. They have all sorts of ways of dealing with their leaks rather than saying they shouldn't occur. And of course, the converse in everything I said could be true. If you simplify an operation too much, which we hope will not happen, shorter, simpler surgery can lead to more complications and lessens the opportunity for surgery and decreases the respect and usage of our discipline of metabolic bariatric surgery. I mean, in a sense, that happened with the band. The band wasn't very difficult to do. It was simple to do and had a lot of complications and lost us a lot of respect. Next slide. So, outcomes. If I look at everything, I believe the SADI-S may have certain metabolic neurohormone advantages over the biliopancreatic DS. I don't know why, but it seems to be true. And the SADI-S may have certain nutritional advantages. That may only be linked to the fact that the common channel today is much longer than we used to do. As I said, when the biliopancreatic diversion of Scopanaro was first introduced, there was a 50 centimeter common channel. I was frightened from that in the first place. I did a 75, then 100, and then 125, and ended up doing about 125 to 150, which is about half of what's being done today. Next slide. So in conclusion, there is no definitive randomized controlled trial of SADI-S biliopancreatic diversion. I mean, a trial that goes on for 5, 10 years, looks at everything, but I'm not sure it's necessary. Randomized trials usually are between two very different things. You can have a randomized trial between SADI and gastric bypass, which has been done by Dr. Torres. But can you really do two things that are so similar without taking in thousands of patients, randomizing them and so on? I'm not sure we need a randomized trial here. SADI-S is simpler and faster to perform than the ordinary BBD-DS, and that's a fact. The SADI-S with respect to metabolic, nutritional, weight loss, and comorbidities outcomes is not inferior to PDS-DS and may actually be superior. Next slide, please. And that's my final slide. Perspective. The two anastomosis jejunal-ileal bypass gave way to the single anastomosis jejunal-ileal bypass. The two anastomosis biliopancreatic diversion DS will probably give way to the single anastomosis SADI-S. And I think this is the future. And I think this may be the future for taking the best operation with over 95% revision or regression or anything you want to call it of type 2 diabetes, maybe the best operation for weight loss, the best operation for metabolic parameters, the biliopancreatic diversion duodenal switch SADI kind of construction. And by making it into a single anastomosis, it may rise from having 1 or 2% of the operations being done worldwide to a larger percentage. Maybe not for all, but a larger percentage. And maybe this is good for the population we are trying to serve. And finally, metabolic surgery is always in evolution. Otherwise, we'd be sort of static, and we are not a static discipline. We look to the future, we innovate, we come up with new ideas, and we improve upon old ones. And that's where we are today. So if I had a final word to say, I would think that SADI-S is here based not only on the data, but the acceptance from IFSO and ASMBS as a standard procedure. So I don't think one has to fight anymore to say SADI-S may be as good as. It's good. And it's a great operation. And I think more of them should be done. Well, thank you ever so much for listening to me.
Thank you very much, Henry. As usual, you nail it and you make it very concise, and those who have ears to hear have heard. At this time, we'll move on to the live surgery part of the operation. And then after that, time permitting, we might have further panel discussion. Who is the fellow who's going to do our... The fellow, Dr. Shashank, would introduce the patient, and Dr. Bhandari will proceed with the procedure. Shashank, go ahead.
Thank you, sir. Welcome to Moscow. Today we have a 37-year female with a weight of 115 kgs with BMI of 44.9. She's a non-vegetarian by diet, has no significant comorbidities. Her serum protein level is good, 7.8, with albumin of 4.2. Her HbA1c is 7.5. She has been tested negative for all the viral markers, including COVID-19. Over to sir. Thank you.
Okay. I'll invite all my invited faculty members to be moderators. Once Dr. Bhandari starts operating, I want you to feel free to ask questions and comment. And so I'll turn over the operation at this time to Dr. Bhandari.
Okay, so Good afternoon, everybody. Good evening, everybody. Good afternoon and good morning to all those who are in United States of America. Actually, this patient was induced a little time back. So me and my colleagues, we thought that rather than keeping the patient intubated for a long period of time, let's start and do the procedure. So let me first introduce you. Can I have the external view for the port position? So the external view, as you can see, I'm standing on the right side of the patient. My patient is exactly in the supine position. And now if you see, I have an optical port here, which is just supraumbilical. We have two 12 mm ports, both in the anterior axillary line, exactly in line with the optical port. So these two are 12 mm port, one on the right, one on the left. The right side would be used by me to do most of the stapling and my suturing, and the one on the left side will be used by my assistant in case he wants to do some assistance. We could have done away by doing the left-sided port by using a 5, but I always feel very comfortable by using the left-sided port, means this one which is for my assistant as 12, because it gives you the beauty of putting in the gauze. Whenever there is some oozing, you can put in a gauze immediately. So I use this as a 12 mm port, and we have always been very satisfied. The 5 mm ports are two, which are both in the subcostal area, 2 finger beds below, and they are both in the anterior axillary line. So as you can see externally, I am working with a total of 5 ports. I have already put in a liver retractor, which is a 3 mm non-scarring liver retractor. Now, as you know that we perform endoscopy of most of these cases, we already did endoscopy. So at our center, we do not perform the endoscopy pre-operatively, as in before taking the patient into surgery, but we perform all these endoscopies intraoperatively. And before I joined this live session, I had to do it because the patient kept on for anesthesia for a pretty long time. So I thought I'll do an endoscopy. The point I wanted to make, we are one of the centers which follow a very special protocol, that we do all our endoscopies only intraoperatively and not preoperatively. And most of these patients give a blanket consent that we can change the procedure according to the intraoperative endoscopic findings. There are certain benefits of this particular way or method of practicing in bariatric surgery, and there are certain disadvantages. And I think we have already had a long webinar on intraoperative endoscopy and why not preoperative and why intraoperative, the advantages, the benefits, and our data. But for this case, I have already done it because I wanted to save some time. Can I have the internal view? Now, what we already did just before we started with you, that we mobilize this entire sleeve. So as you can see, the sleeve is mobilized, but the crucial point I wanted to make is that we in India would not do a SASI bypass or keep a common channel of 200, but what we do is a SADI-S, which I think Amar also explained that he had a lot of complications and then he stopped doing it. So we do a SADI-S, which means that we do not count from the ileocecal junction, but we exactly count from the ligament of Trides and take a 180 centimeters loop. But before that, I need to make the sleeve. So I already started to mobilize this greater curvature by the omentum, and the gastrolysis is done until 6 centimeters from the pylorus. So you can see this is my pylorus, and this is 6 centimeters from the pylorus where we stop to do the gastrolysis. So I will start my firing here. Can I have a blue? Oh, this is it. So the first load is usually the green, although I can do a gold here because I am a little distant away, but this stomach to me looks a little bit thicker. So I start my firing with the green, and we are using a 36 to 38 French bougie here. And this firing is exactly done 6 centimeters proximal to the pylorus. So we have a good amount of, reservoir with antrum left there for the patient to eat, because we believe that this is a combination of a restriction with somewhat hypoabsorption. So we would want the patient to eat well. And we, mostly all these bougies to me are more for a rough idea of the patency of the tube. They do not express the exact volumes, because as you can see that I'm not very abut to the bougie while I'm firing. So that's one of the concepts. What keeps us to the standards is that we measure the length and the breadth of our pouch to keep the volume of this particular sleeve uniform rather than being dependent on the bougie. So that's something which we decided. So which means that I will measure the breadth and the length of this particular pouch for you once I complete this. Along with most of the other leading experts, we already published the standardization of SADI, and I think Professor Antonio, Professor Buchwald, both of them were there in that meeting. I think Andriy was also there in that meeting where we all published this article to standardize the SADJ or the loop BJBs, and this was voted with a consensus from the experts, and we came up with standards. So that's one of the most important papers which we published, and we were assisted by a lot of these surgeons in writing that paper, and Jane Buchwald was one of the lead authors of the paper along with all of the surgeons. One of the most downloaded papers of obesity surgery for standardization of over 30 bariatric procedures. So this is a sleeve. Now I will just measure the length of the sleeve for you, which I created. As I said, we did gastrolysis 6 centimeters from the pylorus. This is the GE junction. So that's around 10 centimeters. And then from here, I would measure till the time my staple line starts. So that's around 18 centimeters. So 18 centimeters would be the length of my pouch in the sleeve, and the breadth is mostly uniform all along. It's around 2.5 centimeters all along the length of the pouch. Usually we have to take it at 5 different locations and then we sort of average it out, but it's around 2.5 centimeters. So what I wanted to express is what we do is not as per the bougie size, but what we do is as per the technical standards which we published and which all of us are following now. So this is our sleeve. The volume is around 120 cc of this sleeve. Now what I also did, just to save time, is that as you can see, I have preserved the vascularity of the pylorus and the muscle. So we do not devascularize this entire area here, and we divided around 3 centimeters of a duodenal cuff, as you can see here. Just before we started this procedure, we can see that this is the pylorus here, and we have around 2.5 to 3 centimeters, although if I stretch it, it would be around 3.5. So that's division of the duodenum, which I did just to save the time. Most surgeons here are already doing this procedure, so there is no need for them to understand as to how. But the point here, while we divide, we maintain the vascularity of this particular area and the nerve endings of the pylorus. I would like to do a very little bit of dissection here because I'm trying to make a 4th layer, or maybe a layer which is a posterior layer. I will not talk 4th, 3rd now. I'll say a posterior layer. So that would be like sort of a stay here. So I'm just trying to remove these little bit of flimsy additions of the first part of the duodenum from the pancreas. And usually there are small vessels here, so I'm a little cautious that I do not damage the pancreas and those small vessels and cause embarrassing bleeding. So that's the standard what I do, and we get a good amount of area here after dissection. So the cuff length usually would increase if we take this area here. So that's what we usually do. Once we have divided, we try and take good area so that posteriorly we do not suffer with that margin of taking the posterior layer. So this is the pancreas, and as you can see, we are using the coagulation mode here just to avoid a little bit of oozing, which usually takes place. And I think that's fine. So now what I'm going to do is I'm going to just make my patient a little bit more supine. It's a we get slight head up we gave, and then I'm going to count for you the ligament from the ligament of trites around 180 centimeters. So this would be basically a SADJ or a loop DJB rather than a SADI, and the principle is the same. It's just the measuring of the limb lengths. So I usually would avoid making 250 centimeters and keeping that short a common channel, because I believe that that's too much for these patients, although Amar is publishing the data and he agrees. I have some experience from the mini gastric bypass. We do a lot of them, the one anastomosis in our country here. And at our center, we have done close to 4,000 mini bypasses, one of the largest series. We learned that a common channel of less than 250 centimeters is a big problem. So this is the ligament of trites. As you can see, there's the inferior mesenteric vein. And I'm going to count around 180 centimeters from here. So that's 10, it's 20. I'm using my graspers, which are 10 centimeters still here. You see the markings, 30, 40, 50, 60, 70, 80, 90, 100, 110, 120, 130, 140, 150, 160, 170, and that's 180. So this is good. That's the sort of length which we choose for this patient, and that's the length which we choose for even one anastomosis bypasses we do. I'm using a Vicryl suture here, which is a suture which I usually would use for taking this layer, which is the posterior layer. So as you can see, one of the, you may say, a benefit, advantage or a disadvantage of this particular technique, what we are using is that if we are not mobilizing that vasculature of pylorus, the area 6 centimeters from the pylorus until this part, one of the problems which I faced is that this area is not as mobile as we want it to be. But then I have had occasions when I mobilized the complete vasculature, it got congested. So it did not give a very good feeling to me. Now, specifically, this problem happened to me in revision cases. So that's something which I am a little more careful about, because sometimes that can be a problem. Although we never had leaks in this area, but still. So I'm going to take a posterior layer.
Point here, Dr. Mohit, this is Dr. Amar.
Yes, yes.
Can I add one point here?
Yeah, sure.
We're talking about the congestion, right? So actually, to prevent the congestion when you are mobilizing the total thing, you need to preserve the lesser omental vascular arcade branches that's supplying the first part of the duodenum. So if you divide too close to the duodenum on the superior margin, you are going to end up in congestion. So if you keep that, if you preserve that vasculature, congestion will not be there. So even mild congestion is also there. That disappears.
Yeah, mild. You know, I never had a problem. I will tell you honestly. I even so much so that previously we used to divide it completely. You know, we never had problems, even if there was congestion. But you know, somehow I believe that one of these patients who came to us had a stricture, and then you know, a post-pyloric stricture. You know, once it causes fibrosis even in the pyloric muscles, that can be a very big problem, and that's difficult to deal with. So I even if I preserve the arcade, I like to see this area a little less congested, and obviously we are not able to make an anastomosis as large as we do for maybe a gastric bypass or maybe a one anastomosis, where even if you
Go ahead.
And so Mohit saying something more on the congestion front. In the ileal interposition, when we divide the first part of duodenum, we mobilize that whole area, including on the lesser curve. We divide the right gastric artery also.
I know you do that, and I have assisted you in certain cases. We have seen congestion, but nothing happens actually.
Yeah, that's right. At times you see a light amount of bluish, tinge there, but the supply from the left, gastric is so good with the gastric, anastomosis inside, that we've never had a problem, never seen a problem. And for those where you might find sometimes if bringing up the ileum or the jejunum like you're doing here is a bit on the tight side, if you mobilize that, your anastomosis becomes very, very relaxed.
Yes. So you want to say the omentum, right?
No, I'm saying if you divide on the superior aspect of the duodenal stump also,
Okay.
of the in the region of the pylorus, where the right gastric is, and we free even on the lesser curve, gastrohepatic attachment.
Yeah.
So it gives you a great amount of laxity for doing these anastomoses.
Yeah. But I think my loop is not under pressure here.
It's not.
I mean,
I'm saying if somebody finds it.
Yeah, sometimes you can encounter that the tightness, and sometimes you may have to divide the greater momentum to accommodate. But when you divide the right gastric artery, that situation will not be there. I never had to divide this greater momentum to accommodate the anastomosis.
As you can see, this is the pyloric muscle here. This is the pyloric muscle, and we are distant away from that. I was concerned when if you remember, we had Oreo here, and we did some cases in Indore, and you were very correct. When we were doing a diverted ileal interposition, we had some congestion. Yes. And I asked the same question, and Oreo was so confident that nothing is going to happen, because I think that time I learned that the left gastric, as you said, is a savior vessel, and at most times we can get away with it. But what about the rate of strictures? I don't know. I mean, all we are concerned is just the leaks, but what about the strictures? Have you ever? I mean, I don't have.
We never encountered strictures. We never encountered. Actually, I did endoscopies also on the patient, but none of them had any stricture in that area. It's actually very big. The anastomosis size is very big.
Okay.
The main thing is if the anastomosis is wide enough, you never get a stricture. Mm-hmm. There were 2 strictures we had encountered in the series we did in Turkey, in Istanbul with Alpa Çelik.
Yes.
That is when the size of the anastomosis was less. If you make a wide anastomosis, we've never found a stricture.
Yeah, so most of us, this is a 2 centimeters, as you can see, and most of us are making the same size. I personally had one such case where we had a stricture, and we had to sort of dilate it, and that patient created a lot of problem.
But Mohit, I keep around 4 centimeters. The total breadth of the duodenum, I keep the anastomosis. So it's we never face that.
So which means that you basically do an end to side, right?
Yeah, end to side, yes.
End to side. Yeah.
This process started with ileal interposition, because initially I started doing ileal interposition surgeries. So the same I continued with SADI-S also.
Yes. Okay. So if you use the whole width of the duodenum, it's a very wide anastomosis.
Yes.
Yeah.
Hi, Mohit. Good morning. Rana here.
Hi. How are you?
Nice. Very, very good. Very nice to see you, and obviously fabulous skills. And I think for people who are starting out, maybe mobilizing the great. I know you did a nice in situ dissection of the duodenum, and were able to get around. But if somebody is starting the procedure, maybe mobilizing along the greater curve, finding the gastroduodenal artery. Yes. And then going around might be much easier. Obviously, it would be an easier way to teach someone who is new to the procedure. And I agree with you. You don't have to take the right gastric at all times, but sometimes in the super obese patients, taking the right gastric drops the entire duodenum down and helps.
So I'll tell you, I was doing that previously, and this I stopped doing it because maybe the look and feel of a congested duodenum sometimes scares you. So I just sort of stopped doing that.
I don't know, for reasons known, unknown, I revised two sleeves I revised two of my sleeves to SADI, and both I did when Antonio was here at my center, and we could see some congestion, and Antonio said that it's okay. I mean, it's fine. He said that it would be fine. You don't need to.
Dan, do you have any comment about this? Go ahead, Dr. Cottam.
I've done over 1,000 of those dividing the right gastric, and yes, there's a little congestion, but we've never seen a problem. So I agree with Rana that it really is easier to take the whole greater curvature down, but no, I would be lying if I said that this looks fabulous. So, I mean, I don't think there's a wrong way to do this. The wonderful thing about this operation is that as long as you find a safe way to do this anastomosis, it really doesn't matter how it's done, because it's not an integral part of any of the weight loss or metabolic portions of the operation, right? It's not like the gastric bypass where you're talking about how much restriction you're giving. It's just—
Yeah, I think I agree with what Dan said, that it's more of like the technique will not affect your results.
Yes.
Like what
Another
happens in a
comment?
gastric bypass, if we
Yeah.
make a very large pouch, we have less weight loss, more marginal ulcers. Similar thing is not being seen here. I agree. And once we do an anastomosis in quite a standard way, I think most times we will get cleanly out of it. So yeah, it's true. But to be honest with you, I discussed last time, we had CK Huang, and CK was one who is from Taiwan, and he did a lot of publications on the loop BJB, and they have stopped doing this procedure in very large volumes. In fact, now they do mostly sleeves and gastric bypasses, and the reason they say that it's difficult to train fellows, and they cannot trust fellows doing this sort of an anastomosis, because at most times this has more complications. So you feel it the same way, or your fellows are very happy doing this? I mean, it was easier to train fellows into gastric bypass than this procedure.
Antonio, what do you think? Unmute yourself.
Well, I agree with Dan and Mohit, but the problem, in my opinion, if we want to expand the surgical procedure, and I think it's going to be important to make a dissection more, I would say, democratic, that everyone can see everything. And I think we must advise the beginner in this procedure to do the dissection from all the greater curvature down for seeing everything. If you don't divide the right gastric artery, the blood supply will be enough, even if you divide maybe enough, but I think in terms of standardization, as Professor Buchwald said, I think it's going to be much more important to try to see everything you are dissecting. I mean, if you pull up all the antropyloric area and you see the gastrointestinal artery, you see the pancreas, you see everything, I think, in my humble opinion, it's safer for the majority of beginners performing this dissection. For the very skillful surgeon, it doesn't matter. We don't care. But for the beginners, I think it's going to be much important to be safer regarding seeing everything. And another important issue regarding this procedure is don't, in my opinion, my advice would be don't do the sleeve until you finish the dissection of the duodenum, just in case you have some problem and you have to stop performing the procedure. I'm going to make my two comments on that. And another comment I have, probably using, the device that Dr. Bhandari is using, probably with a standard needle holder, you can control a little bit, the wide of your stitches. But anyway, it's just a personal approach to that.
So can I ask
ASMBS,
a question to all of you involved in duodenal surgery, SADI-S, or the duodenal switch? It's an observation that, as we know, that hardly 1% or 1.5% of worldwide surgeries are BPD-DS. with the SADI-S becoming a little easier, we expect that some more surgeons will actually move into this. But the reality we see in the world is majority of the surgeons, the average surgeons, are afraid of working around the duodenum with dissection of the duodenum. And that's an observation. So everyone wants the sleeve, or you want to move on the gastric side with an MGB or an RYGB. So if this is, as Antonio said, and as Rana and Daniel also pointed out, a standardized clearance of the greater curve, clear observation, going up to the gastroduodenal artery and clearing so that you're safe all the time and you don't have a vascular bleeding, only then probably more and more surgeons might take to this.
I agree,
Mohit,
Surendra.
yeah, I agree with what you say. You know, somebody as skillful as Mohit, you can get around the duodenum and handle the problems. But, you know, last ASMBS, when I was chairing the video session, I actually selected a video, and Dr. Cottam knows the video I'm talking about, but there was a robotic duodenal switch being done, and unfortunate injury to the portal vein. And, you know, the patient had 2.5 liter blood loss because, you know, of the complete, you know, they lost their way while dissecting around the duodenum and ended up with the right portal vein injury.
Okay.
And caused a problem. So I think while doing this procedure, it's important to standardize. Mohit has done a beautiful anastomosis. I think some of the points are start on the antimesenteric side of the bowel, so you don't run out of you know, bowel real estate when you're completing the anterior anastomosis. And for most beginners, mobilize the entire greater curve, visualize the gastroduodenal artery, encircle the duodenum, and divide it. And then if you think there's too much tension, lift up the duodenum and take the right gastric and drop the whole duodenum complex down. That would be the that would be my humble 2 cents.
I would add that I don't think we should make operations down to the lowest denominator of technical surgeons. I think we should raise the level of technical surgery to do the appropriate operations. And I'm afraid that there are a lot of people, and the sleeve is a perfect example. A lot of people think they can do a sleeve and they have leaks and so on. I think we need some sort of a credentialing system for surgeons and a teaching system for surgeons. And basically, some surgeons shouldn't be doing this.
I absolutely agree with you. I think what we're going to do is probably go back to the old principle, find an effective operation and work on making it safe, and then making sure that people who do it are trained. I've always heard Henry talk about the learning curve. It's always nice to talk about a learning curve when you're the one operating, but think about it when you're the patient. We should not be talking about problems that are due to the learning curve.
Good point. Very good point.
Yeah.
That's an amazing observation. I mean, both Dr. Fobi and Dr. Buchwald, I agree on theory, but if you look at the spread of fellowships in the US that we have, 70 to 80% of programs do about 70 to 80% sleeves. So these fellows are coming out with very less suture skills. So now if you then, you say that, you know, we're not gonna allow them to do the operation, then, you know, we either have to revamp the entire system to figure out how to better train, or this operation is still going to be 1% of the of what we do. That's the unfortunate truth.
This is the reason I'm saying, you know, regarding your comment.
That's going to happen.
Sorry, sorry, Mal. You know, this is the reason, because I'm saying, you know, when we are talking about the implementation of a new procedure, of the advanced procedure, we have to think not in the more skillful surgeons. We have to think about the fellows and the younger people, and then to share with them You know,
Sir,
your
GCT
own
निकाल
career,
लीजिए.
not to be so skillful and to try to
Sir, GCT निकाल.
explain to them the safest way of performing. I mean, my humble opinion, the safest way of approaching the duodenum is to bringing up all the greater curvature and the posterior antropyloric area to see everything and to be a very safe way.
I absolutely agree with you, Antonio. But the thing is, like Dr. Buchwald said, in his simplistic way, we don't want to make an operation too simple and then recruit incompetent people.
Agree, totally.
Because, my prediction is that the sleeve is going to be where the lab band is in about 2.5 years. Because when we start seeing this 30 to 50% rate of inadequate weight loss, and then seeing the incidence of GERD, we would have to do something different. What I've observed listening to both Amar and Daniel and Antonio is there is a difference in the occurrence of GERD after the SADI as compared to the one anastomosis gastric bypass. Am I correct?
Yeah, you're correct. You're correct. And then also shows that
yeah, sorry, go ahead.
It's
I
not
didn't see any GERD after SADI-S. Actually, it has improved. So even for GERD people also, I prefer to go for SADI-S only. And one more point here is why this procedure is not popular is not just because of technical difficulties, but people are afraid of malabsorption. Even though it's actually malabsorption is very less, people think that SADI-S means it's malabsorptive procedure. So that nomenclature of using restrictive malabsorptive has to stop. It has to be based on neurohormonal changes. It's a metabolic procedure. You need to concentrate on that part to publicize like this surgery.
Mohit, would you consider doing a post-op endoscopy in this case?
Yeah, I'll do an endoscopy.
Yeah.
Just to show what sort of anatomy we have.
And while he's getting the endoscopy ready, Rana, I know you do the BPDS room. Why? After looking at such a simple procedure without about the same amount of effectiveness, do you think you start doing the SADI more than doing the DS? Why? Rana? Dr. Pullatt? Unmute yourself.
Yeah, I was actually one of the first people in South Carolina to do the SADI, but unfortunately in the Carolinas, we've had some issue with insurance people decredentialing a surgeon for doing SADIs. So that's the only reason I don't do SADIs, and I still do them on my self-pay patients. But now with the new ASMBS recommendations, we've been doing more of these. And when I do my duodenal switch, I do the SADI first and then divide the loop. So it's pretty much, you know, I stop one step short. But I mean, I agree. I think the SADI is just as effective and it's going to be fine. Mohit, did you close Peterson's space or?
No, I'll be closing it. I'll be just closing it. I'm just trying to do the endoscopy as Dr. Fobi said. I'm just getting the suture. So we are inside this duodenum now, jejunum now, as you can see.
Sometimes that angle is really hard with the scope to get into.
Sometimes I'm usually what happens is by the time you try and do it in a way you want to, a lot of air goes inside. So I just don't force it.
Sure.
But nevertheless, that's the pylorus there. I pull my scope back. That's the pylorus. Can you see? And that's where is the anastomosis. I'll pull it back. This is the sleeve.
Mohit, have you ever had a situation where the efferent limb is completely blocked off, or when you suture it?
No, never. Because my way of arranging this loop is in a way, because we learned from mini gastric bypass that it never happened to us. Never.
Yeah.
The only one issue probably I would say I had is that these patients have, we're talking about reflux and issues. I don't know why but with my patients, the reflux is still there with the SADIs. So we don't know. I mean, I feel that since there is pylorus, the eating is not as comfortable as a gastric bypass or a mini gastric bypass. It's very restrictive eating, just like a sleeve. So I don't know why that happened to my patients, but we have a smaller series compared to Amar and maybe Dr. Ugale. So I think they are much better judge in guiding us when it comes to SADI. But I have patients who have problems with reflux after SADI, after SADJ, what I wanted to say.
I'm going to have
for the
people to go to right now. So that's a wonderful operation. Thank you, everyone. I appreciate it.
Thank you. Let me just ask a question. Daniel, do you close this defect?
I have not ever closed the defect, and as of right now, I'm still on just one internal hernia, and it was really just scar tissue that had pulled the afferent limb underneath and tacked it down there. So I'm, a classic vascular compromise internal hernia I've never seen.
What about you, Dr. Torres? Do you close this defect?
I don't close the defect in my department, but when I'm operating outside Madrid, in other places, I close.
Okay, because you might not be
able
to follow the patient.
You're right, just in case.
I
don't think it's necessary. I agree with Dan. We haven't had any problem.
Can I have a patient
but
note?
I have to admit that probably, if something happened and you are not there, you are not the responsible surgeon, you have to take into account this. But I agree with Dan. We don't close in our department.
Dr. Lavryk, in Ukraine, I know you mostly do the RUIDS, right? Is he in? Andriy? I think he must have disconnected. Okay, good. We've had does anybody have any comment before we close up?
Yeah, I think for the beginners, if they have some worry about the afferent limb, one of the tricks you can do is get the anesthetist to pass an OG tube and just direct it into the afferent limb, so you're not closing it off completely. So that's something that you can do if that's an issue. I close this defect routinely, both in Roux-en-Y as well as in SADI. And I've seen in a Roux-en-Y configuration, duodenal switch, I've seen the entire limb twist, and the patient get chylous ascites from just obstruction.
So that's the closure.
Can I say one more word?
Sure.
Oh, I just want to get for one more word on the skill of the surgeon. As I said, we are a field of innovation. And when we come up with something new, better, that will always be accepted. We say operation A is not or was not as good as now what we're doing B, that's fine. It goes with the modern feeling of anything when they say this is now an improved formula. It's improved and therefore you should use it. But I don't think we can get away or should get away with fatal complications no matter what we do. And so once again, I make a plea that for all of us in this field, we got to make sure that the surgeons who are coming into the field are technically competent. They don't have to be geniuses, but they have to be technically competent. Thank you. Thank you for having me. It's a pleasure.
Thank you. Let me just ask Dr. Torres one more question. I see you do quite a few sleeves.
Yeah.
Do you see incidence of GERD in your standalone sleeve higher than in the SADI, or is it about the same?
No, it's about the same. We study our patient very closely when we are some symptoms or endoscopic findings of GERD. If we have a very symptomatic patient at the beginning in the workup before surgery, preoperatively, we do, if there's some esophagitis or very, very symptomatic, we do pH-metry and manometry in all our patients. So we make the decision based on that. If it's very pathological, the Mister score, or a very high percentage, the pH below 4, we do a Roux-en-Y gastric bypass. but we don't do a sleeve or we don't do SADI-S. But if the patient has not very symptomatic, no endoscopic finding, we go all straight for a sleeve or SADI-S procedure. We have to take into account, all the information that Dan Cottam gave to us, regarding, the girl residing after SADI-S.
Okay. Andriy, you're finally back on. Any comment before we close up the session?
Yes, of course, it's important close. And I have one question to Mohit.
Yes, go ahead.
Thank you, Mohit, for a very nice operation. And my question is about what size of common channel in this case?
So this we did not count any common channel because the limb length, the BP limb length is 180 centimeters. Now,
and it's similar of MGB.
Pardon?
It's similar of MGB.
Yeah, it's similar of MGB. So our philosophy is same in our 3000 mini gastric bypasses, and I did with Dr. Fobi here. We kept the standards to 180 centimeter of limb length, and we have never counted the common channel. And our protein deficiency rates in Indian patients are very minimal. We have applied the same philosophy here to this this procedure. So that's why I'm not counting the common channel.
Thank you.
Well, thank you all very much.
Mohit, wonderful operation, and as usual, great skills. We'll see you soon in person. And thank you, Dr. Fobi, for the invitation. Thank you, Mohit and team. That's amazing.
Thank you, Rana. Thank you, Professor Buchwald. Thank you, Andriy. Thank you, Dr. Ugale, Dan, everybody.
Can I add one point?
Dr. Antonio.
And so, Mohit, can I say this? So
Yes.
this operation was little different from the SADI. I mean, it's not SADI, but it's SADJ.
Yeah, SADJ. Yes.
Okay.
Yes.
Yeah.
So I would say it's a loop DJ bypass, right?
Yes.
I just want to add one point here. Actually, I do sleeve loop DJB with 250 centimeters. So what I observed is I didn't have any malabsorption with 250 centimeters also because of the preservation of pile rust. And we don't need to measure the common channel when you are doing sleeve loop DJB because common channel length will be approximately 4.5 meters based on I have been measuring the bowel length for the past 4 years. So average bowel length is 7 to 9 meters. So if you take in that count, common channel length will be 4.5 meters. I never encountered malabsorption with sleeve loop DJB actually.
Actually, Dr. Amar, this is very controversial because when I was doing 250 centimeters of MGBs, we had a lot of malabsorption. We published it. So
yeah,
I mean, considering that you have a pylorus there, it makes your procedure more restrictive. So I don't know. I mean, we all across. I mean, you talk to anybody who published on it. MGBs of 250 centimeters have not worked. So I doubt your loop DJBs or your sleeve with loop DJBs of 250 centimeters. You say that they don't have problems. Let me tell you, most of these problems happen after 5 years. So you will see these patients doing very good and they will land up with liver, very insidious. So, across the world, there is a lot of data on that, and surgeons across the world have gone down to below 200 centimeters with mini bypass, which is not as restrictive as your operation, which you do. So I would still be cautioned at what you're saying.
I would agree with Mohit on this, that it really, I mean, this is the paradox in bariatric surgery. On one hand, with the MGB and OAGB, we say 200 maximum, or now everyone going back to 180 or 150. And then if we say that at times you can do 250 and 300 of the BP limb, and we don't know what's on the other side. Also, Amar, I'd just like to point out that even we've been measuring for the last 12 years, all bowel lengths. Average lengths are 600 to 700 centimeters. We've had bowel lengths of 400 centimeters also. Yeah. So if you take 250 and you don't measure the other side, you may have
absolutely. I mean, Amar, I would say if you are doing 250, please measure the entire bowel, and I would not endorse this. The simple reason is that we had burned our fingers. I have revised some 15 MGBs of 250 centimeters limb length, and let me tell you, first 5 years was honeymoon. Fantastic. I had liver failures after 5 years. We had patients admitting with severe protein deficiency, all multivitamins gone. Even we had to do feeding gastrostomy and then get them back to, So I'm cautious.
No, just want to tell, I am measuring for all the patients, I'm measuring the bowel loops. I was doing sleeve loop JP once upon a time. So I stopped doing that. I shifted to SADI-S completely. So for all patients, I'm measuring, except for sleeve, all bypass patients, I'm measuring the total bowel length.
Yeah,
So
I think that makes sense, because if we measure it, then we know that we are more sure about what we are doing. I agree.
Antonio wants to say something. Antonio,
Yeah,
This is a very
because
nice
I'd
discussion,
like
but
to
we have a certain
point
time
out
limit.
that sometimes, to measure all the bowel is not a very easy thing, especially in bariatric, in very, very heavy patients.
Absolutely, absolutely.
Sometimes it's a very challenging issue, and you can cause some damage than more benefit to the patient. So don't, in my humble opinion, don't try to measure all the bowel in every patient, because sometimes if a patient is 60 BMI and you have to count all the bowel, it's going to be dangerous. You can damage the bowel. And sometimes, it's a portion of cautious regarding to standardize to measure all the bowel in all the patients.
I'll tell you this point. Actually, the way of measuring is different for me. So what I do is I measure from the ileocecal junction up to the anastomosis. I'll stop there and I go to DJ flexion and measure from there. So if you measure from one end to another end, you are going to damage the bowel. If you measure from the both ends to the anastomosis, risk of damage is less.
I agree, Amar. That's a good point. I mean, this is good. This is a good point. If you measure from the anastomosis to one of the flexures, the IC or the DJ, it's simpler. I agree. Absolutely.
Henry, you're going to make a comment.
Just a matter of fact, in the old days, I did about 1,000 jejunal bypasses open. And I measured the entire bowel in each one of those cases, because what I was looking for is obesity associated with length of the bowel. And the bowel was anywhere from 400 to 700 centimeters from ileocecal valve to the ligament of Treitz. And it had no relationship to the degree of obesity. So some of the most obese patients had shorter bowel, some of the lesser obese patients had longer bowel. But the length of the bowel, that we measured, and it can be anywhere between 400 and 700 centimeters.
Well, I think I would end this session by saying what I learned tonight is we don't really know the hell what we're doing. Basically, we had surgeons who, what Henry said made sense. I see a distinct difference maintaining the gastroduodenal axis when you do the loop duodenojejunectomy, as opposed to doing a gastric segment and doing a gastrojejunectomy. And so there might be something more metabolic than the lymph length that we surgeons are measuring. And hopefully, as you publish what you do, we might come up with an answer. With that, I'll say thank you all very much. Excellent operation, Mohit.
Thank you. Thank you, everybody.
You want to close this session? Promo for next week. Next week, we'll be talking about a sleeve gastrectomy plus, which means ilia anastomosis, which is a similar principle, but looking more at the metabolic effect. So let's run the promo, and then thank you all very much. I'm sorry for the audience. If you have any questions, we would answer them by email. And then this will be, the whole recording will be posted on the VBU website. And each of the faculty members, you'll be getting a copy of this presentation today. Thank you, Mohit.
Thank you. Thank you, everybody. Bye-bye.
Mohit, congratulations. Nice surgery. Nice procedure. Mohit, bye.
Thank you. Thank you. Bye-bye.
Bye, Henry. Bye, Mark.
Thank you.
Surendra.
Namaste. 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 Am I sure the promo for next week?
Hello. Today we don't have the promo for the next meeting.
Thank you. Okay. We can leave the session then. Thank you.